Hi, everyone. Thank you for joining us for today's Doc Talk. My name is Samantha Paulo, and I serve on the board of the Providence Children's Health Foundation. I know that many of you have invested in the work that we do at Providence, and I'm delighted that you're here with us today. Now, today we're going to hear from Dr. Kara Johansen about the important role of caring for the mental health of mothers. I'm so inspired by the work that Providence is doing to support families and feel passionately about today's topic because I know firsthand the risks of postpartum depression and the importance of finding balance as a mother. I am pleased to introduce Dr. Kara Johansen, who works within our Providence Children's Women's Clinic. As a psychologist, she aims to foster a nurturing environment where the healthy relationships can grow, allowing infants and their caregivers to bloom. Dr. Johansen attended medical school at George Fox University and completed her internship and fellowship within the Cherokee Health Systems. Prior to joining Providence, Dr. Johansen practiced at a clinic in Tennessee where she advocated for and helped to recreate wellness appointments for mothers and their babies. In her spare time, she enjoys knitting, walking, riding bikes with her children, reading, cooking, and swimming. Please help me welcome Dr. Johansen.
Thank you, Samantha. Good afternoon, everyone. Thank you so much for taking the time to join me today for this very important topic on perinatal mood disorders. Appreciate you all being here. I just want to acknowledge all of those here today that are grandmothers and mothers. Maybe some of you have experienced these symptoms yourselves or you've walked alongside of others. I'm so thankful that you'd be here and that you'd be interested in this topic, wanting to learn more and to figure out ways to help. So I just want to tell you initially how I got into this work. So I spent over a decade working with babies, children, toddlers, adolescents, and then I started working with their families. And I realized that the caregivers are the foundation for a child's health and well-being. And so I decided to come back to the beginning and focus my efforts on women in pregnancy and postpartum period when babies are completely dependent on their caregivers for survival and their optimal development can begin. So this next slide really demonstrates that. I came to Providence to cherish parents, because we know that that's the foundation for a child's growth and development. So what are we talking about today? We're going to be talking about perinatal mood disorders, which include depression and anxiety. I want you to visualize right now 7 of your family members, maybe your friends, colleagues, neighbors, 7 of them, and consider that one of you will suffer from a postpartum mood disorder. According to the American Academy of Pediatrics, 400,000 infants are born to depressed mothers. That's a lot of babies, and 1 in 7, that affects a lot of women. We know that postpartum depression symptoms can come on and last anytime during that first year, from the birth of a child all the way through their first birthday. And we actually are only treating about 15% of the mothers who experience postpartum depression. 15%, despite the multiple contacts with medical providers that these women are having in pregnancy and the postpartum period, we're missing postpartum depression and anxiety, and many women are going without treatment. Postpartum depression is very, very treatable. We know it's the #1 complication of pregnancy, and we know that there's a lot of negative health outcomes for mothers and infants and their families when they are struggling with postpartum depression. So some of the negative consequences of postpartum depression and anxiety include thoughts of harming themselves, maybe thoughts of harming their baby, not bonding with their babies. We have even seen preterm birth and babies that are smaller for their age, being born with low birth weights. We see a lot of disruption to the baby's emotional regulation, and maybe even their cognitive abilities. So postpartum depression really affects the baby too. And later on in life, the kids that I was working with the kids who had the behavior problems, like ADHD and ODD, those things that oftentimes come as a result of those early interactions with moms. Increased behavioral problems, like I mentioned. These children oftentimes have poor peer relationships, demonstrate poor self-control, and they too have been shown to have an early onset of depression. Higher risk for mood disorders for these children. So the impact is really great. And the need for early intervention is real. So I'm sure you've heard of baby blues, and I just want to take a minute to differentiate baby blues from postpartum depression. So baby blues comes on usually within the first 2 weeks and only lasts, up to those about 10 days in duration. Mothers often have crying spells. They may be plagued with irritability. They're not sleeping well. They've just brought a new baby home and they're not sleeping well. There's lots of things happening in their bodies. So they may be more nervous, maybe about milk production. They're having to care for their healing bodies. There's some, emotional reactivity or some mood swings. One thing that's not present in the baby blues is thoughts of harming themselves. So those suicidal thoughts are not present in the baby blues period, those 10 days. What's different with postpartum depression is that it lasts longer than 10 days. Those 10 days come and go and the symptoms remain. So they come on and they stay on. And they often come on within the first month, but can come, like I said, all the way up to the first birthday. Unlike baby blues, that happens to be about 80% of women experience some baby blue symptoms, postpartum depression only occurs within 5 to 7%. And the severity of postpartum depression can range from moderate, so few symptoms, to a lot of symptoms that interfere with your ability to care for yourself and your baby. And this is where suicidal ideation comes into the picture, where moms may start thinking about harming themselves. And that really differentiates between baby blues and postpartum depression. So postpartum depression, another thing that we should remember is that postpartum depression looks a lot like major depressive disorder, except now you have a baby who's depending on you for survival and growth and healthy development. So there's a lot at stake here. So what does it look like? For me, I'm going to tell you a little bit about what it sounds like in the clinic, what some of the things that women tell me. One woman told me that worry was a constant companion, and it came on at different times when she was hooked up to a pump or when she was typing out emails at work. She would be fretting about not producing enough milk. Am I going to be able to feed my baby enough? Will I have enough milk? At night, when she would watch her baby rest in the bassinet next to her, her brain was too electrified to sleep. She used the word wired, too wired to sleep. She was exhausted from working all day, coming home to wanting to be with baby, and she couldn't sleep at night. During her drive to and from work, she thought about how her baby had gone with her to and from work for the last 9 months. And now leaving her baby felt like a limb had been removed, only to be reattached each night when she returned at home. So really struggling with wanting to take care of baby, but feeling depressed and anxious all at the same time. Another woman talked about having concerns or being told initially that she would immediately fall in love with her baby. But when her baby was born, she said it was like meeting a stranger. She felt a lot of guilt about why she wasn't immediately in love with her baby. She struggled with a lot of the social myths that motherhood is full of only joy, and she was plagued with depression and anxiety, and she felt ashamed by her feelings. She felt guilty about her feelings. She didn't understand why, again, this time of life that was supposed to be so joyous was also coupled with depression and anxiety. Lots of guilt and shame. Of thinking that being a good mother means you only have happy, joyous feelings towards your baby and towards pregnancy and the postpartum period. I've heard moms say that good moms never need a break, and they needed a big break. And so they felt a lot of guilt and shame over needing a break. I had a mom tell me that she couldn't even read her baby's cues. And you guys can imagine, right? When a new baby comes home, and maybe you even experience this or experience this with others that you know have experienced this, of this baby being able to know the difference between a hungry cry and a tummy ache cry and a dirty diaper cry, and then attributing your inability to know the baby's cues instantly as something being wrong with you. So these mothers desperately want to love their children and take care of their children, and yet they're plagued with something that they think is their own fault. So we think about postpartum mood disorders as having a biopsychosocial explanation. So it's the combination of all of these things that bring about postpartum mood disorders. So we have the biological, and here we have some risk factors for women who experience postpartum depression. We know that if they've had a pre-existing mental health diagnosis, that they're more likely to have postpartum mood disorder. If they have a family history, if that's in their genes, they're more likely to experience postpartum depression. We know that there are social components to this. Individuals with poor social supports are more likely to experience postpartum mood disorder. History of maltreatment, so the things that have happened to you, having 3 or more stressful life events in the year before birth, so socially what's happening to you, your upbringing, where you come from, what you've experienced impacts your pregnancy and the postpartum period. Really young, women younger than 19 years of age tend to have a higher rate of postpartum depression. And also during that 20 to 24-year-old range, there's a higher rate of postpartum depression. Also biologically, going back to the biological domain of this, gestational diabetes puts you at a higher risk, as does a sleep disturbance in pregnancy. So the things even that happen in pregnancy can put you at risk for that postpartum depression in the postpartum period. And then the psychological part of this, the beliefs and the emotions, your resilience, all of that coupled together with the biological and the social components, and the way that you interpret the events can really cause you to be at a higher risk for experiencing postpartum depression. And all of these negative factors, some of these negative factors, the more that you have, the more they add up. And the sad thing is, like, from the last 3 slides that we saw about that depicted the women who experience postpartum depression, is that here they are blaming themselves, being too embarrassed to tell others about the thoughts and the feelings they're having because they're afraid people won't understand, or they will think they're going crazy, or they don't love their baby. And they're blaming themselves for something that they didn't cause, but something that is very treatable. So really thinking about, how do we break the silence of this condition? So let's take a look at who this affects locally. So these numbers are the women in our clinic. We did a OB intake form and gave it to all new patients. And this is what we found. They had a lot of basic needs: food, housing, transportation, childcare. Just looking into what their needs were and the social and emotional support that they felt like they had. We can see that about 14% of them felt like they did not have the social support they needed in terms of getting a ride, having someone look after them or attend to their child. So these women were not feeling supported during their pregnancy. So this is their new OB appointment. So this is a pregnancy period, which is postpartum depression symptoms can start. You can see some of the risk factors in the pregnancy period. So the next slide also depicts who is having mental health concerns. This new OB questionnaire also asked about if they've been diagnosed before. And like I mentioned earlier, having a diagnosis prior to pregnancy is one of the highest. It's correlated to postpartum depression. So depression before pregnancy, depression and anxiety before pregnancy is very predictive to anxiety and depression in pregnancy and then in the postpartum period. And we can see that about 37% of the women that we're serving in the clinic are experiencing or have experienced a mental health diagnosis prior to pregnancy. That's why I'm here. We also see that these women have experienced adverse childhood experiences. So have had traumatic experiences in childhood, about 15% of them. And remember, I mentioned that that was one of the risk factors for postpartum depression. So these women are telling you that they're having depressive symptoms, about 19% of them. About 22% of them are telling us that they're, again, having more of those depressive symptoms. It's just broken this out into feeling down or depressed and then having no interest in things that they once enjoyed, which are hallmarks of depression. And then in the clinic, we see that 8 women are referred each month to a psychiatrist from within the clinic. Again, this is the primary reason that the women's clinic decided to have a behavioral health provider come in and be housed here. I'm in clinic today, actually. So I came to address these concerns that women are having in pregnancy and the postpartum period. So I want to spend a few minutes and just tell you about our services in this clinic. So since we know that about 400,000 women are diagnosed with postpartum depression every year in the US, we also know that about half of these women have symptoms in the pregnancy period. And so we want to do screening. We want to do a new patient screening that asks about prior diagnoses and family history, but we also want to do screening that happens during pregnancy. So in case new symptoms arise, we have a baseline, and then we have something to compare the pregnancy and even the postpartum period. We also know from research that the earlier that we identify and address the postpartum depression symptoms, even in pregnancy and then in the postpartum period, the better the prognosis. And like I mentioned before, the failure to treat mothers in this period of pregnancy and postpartum period has grim consequences for the child, for the mother, for the families. I mentioned already that increased morbidity risk if we don't treat and address this early on. Pregnancy, like I mentioned before, and showing those pictures, moms usually are so excited about bringing a baby into their families. So they come with a lot of excitement, and it can be very scary for new moms to experience feelings that don't feel congruent, don't feel consistent with what they thought this was going to be. So we really want to improve the detection of those symptoms, and then show moms how to manage them, both in the pregnancy period and in the postpartum period. So we're looking at screening new moms for anxiety and depression, initially in that new OB appointment, and then at 28 weeks. And then in the postpartum period, we want to go longer than 2 weeks. 2 weeks, the 10 days, because baby blues often last until that 10-day period. And then we want to assess again at 6 weeks. And then after we do that assessment at 6 weeks, we want to give them an invitation that any time during that first year of baby's life, they can initiate services with a behavioral health provider. So this integrated care model really allows women to have access to the services that they need at any point in their pregnancy or in the postpartum period. Being on site as a behavioral health provider allows me to meet all of the new OB patients and really just start breaking the silence of baby blues and also postpartum depression in that initial visit. We tell patients that we are concerned about their growth and development as caregivers, both emotionally, physically, socially. And this is the place where we start that conversation about what postpartum depression is, if they've ever heard of it, and how if they experience symptoms even in the pregnancy period, they can access help. So we really want to do a good job during that pregnancy period of reassuring women that if they had scary thoughts or they had depressive symptoms, that they could reach out for help. We want to normalize it. Again, this idea of breaking the silence, talking about, yes, the joyous feelings that come along with pregnancy and delivery and bringing baby home, but also the feelings that 5 to 7% of women experience that are not so joyous. We want to help those moms feel like they too can reach out for help and not be shamed and embarrassed. So we talk about, and maybe some of you can relate to this, that becoming a parent is a really tough transition. Normalizing this, bringing it back to home for them, and talking to them about the importance of being open with their caregivers, and if things change in terms of their mood or their thoughts, that they can talk about those. Also want to just say that not only are we providing the behavioral health part of it, or the integrated behavioral health, but also through Providence Beginnings, we're doing case management. And in that slide earlier that showed that women were not receiving enough support, or they had housing or transportation or food issues, our case management here through Providence Beginnings also has the ability to take care of those needs for our women. And I just wanted to give you an example, a story of one of our patients, and I've changed the names here so I can just read you this story and tell you about how our case managers were able to meet a need through the safety net funds. So I'm just going to read this story to you. So we had a couple come in, Jane and Max, who were looking forward to their first baby. They were very, very, very excited. Jane had a history of anxiety in her teens and early 20s, and she had experienced some increased irritability with the pregnancy, but generally she was managing okay. She was coming to all of our appointments, and she didn't feel like she needed anything more than just checking in from the case managers or social workers. So she asked for some information about the perinatal adjustment period, and she even asked for some information about mood disorders, anxiety disorders. And then during the postpartum period, she experienced significant difficulty sleeping, and she lost her appetite. And she described this as not being able to feel nourished. So she wasn't feeling nourished, as she was working really hard to breastfeed her baby. She wasn't feeling nourished herself. And so she became very anxious and panicked. And she would wake up in the middle of the night with feelings of terror. She wasn't going to be able to get enough to feed her baby, and she wasn't getting enough sleep. Her mother actually lived in another state, And her husband, Max, was working a new job and he couldn't take any more time off. He had to go back to work. So they had little in the way of local supports. And they didn't have enough money to bring her mom out to help because finances were pretty tight, but they really wanted the mother to come out and to help. But they just couldn't figure out how to do it financially. So Jane identified that having her mother come and care for her would be really helpful. So along with several other interventions like sleep hygiene and some emotional and physical health recommendations and even building up some support for her, they were able to use the safety net funds to pay a portion of the couple's rent so they could put the rest of their funds towards a plane ticket for Jane's mom. So she was able to come and visit within a few days, and her presence and her support was a huge boost to Jane's path of healing. And the couple and Jane's mom were incredibly grateful for the Providence Family Safety Net funds and the help that they received for them. My last slide there mentioned that without mothers, there are no infants. And I just want to end with that thought that without maternal care, unless we care for our mothers, infants won't make it. And so just really driving this idea home that again, back to my first slide even, that if we are going to do a good job of caring for children, we have to cherish their caregivers.
Thank you so much, Dr. Johansen. We're going to open up the question and answer piece, so please take time to ask your questions. I also want to say if what you heard today was inspiring and you would like to get involved and help move the needle for easing the way for our new mothers, there are a couple areas donors can support. Dr. Johansen just talked about our philanthropic safety net fund. This is a fund used by our social workers who care for new mothers, and the fund supports items such as bridge funding for housing if a mother needs to be on bed rest, car repair, medical supplies. So it's a wonderful program, and I'm so glad Dr. Johansen was able to actually share a story of how it impacted a family's life. Another new initiative that we have is creating and giving out mindfulness kits. The mindfulness kits are based in cognitive behavioral therapy intervention, and they are for new mothers who have been identified with anxiety. The kits include stress balls, tactical sand, journals, and a workbook. It's a $1,500 annual investment to get these to mothers, or each kit is $35. So it looks like we have a couple questions in, Dr. Johansen. The first one is there practice language around caring for moms with postpartum or baby blues? And I think the question is really around hospitalists in the hospital. The question is coming from someone who said that they felt that the nurse in the hospital told her they would take the baby away if she exhibited any symptoms of these emotions, and didn't feel there was support there. So just curious how the continuum of care and this education might be happening now in our hospitals when a mother delivers.
Sorry, I have to unmute myself. Thank you. First, I just want to say I am so sorry for the way that your experience with and the way that you were treated in terms of threats of having your baby taken away. I really do apologize. I think that I can't speak to the hospital. I can say what we're doing here in the women's clinic. And I can say that the more we talk about this, the more we break the silence for mothers, and the more we talk about this, the more nurses are impacted by it. It is a scary thing for individuals to hear moms say that they are thinking of harming themselves. And so they initially go to, oh, you must want to harm your baby, or you're not safe to have your baby. And so talking about how thoughts are different from behavior and normalizing the number of women who experience this that don't hurt their babies, differentiating between the thoughts and the acts is really, really important. I think it is as important to break the silence for providers and nurses as it is for women that are experiencing these symptoms. And so again, I just want to apologize for the way that you were treated, because we haven't done a great job breaking the silence even within the healthcare system. And so I know from working with infants and mothers, the best place for infants is with their mothers. And the best thing that we can do is to keep mamas and babies together and to improve the mental health and well-being of mothers. That's where our efforts really should be.
Thank you. Another question comes from Ashley. I'm wondering if you have any insight or experience with postpartum depression in fathers, how that differs in presentation and management.
Well, I want to be honest and say that's not my area of expertise, but I do know they're doing a lot of research out there right now, and they're saying that, of course, postpartum depression in women affects their partners. And so they're really looking at that and how to help manage it. Because as a family system, we want to really enhance that whole family system from baby to mother to father, all of them. They are finding that there is a rate of depression in fathers, and we're looking at how we could address that. But I don't have specific numbers because that's not the population that I work with. So I apologize, I don't have more information on that. They're coming out with lots of research though on it.
Great. Another question. How can a friend, family member help a new mother demonstrating depression?
Oh yeah, that is a great question. I like that one. You can be really supportive. I like that idea, and I know it's a really old saying that it takes a village. And so this idea that sometimes we have is that we should be able to do it all as mothers. We should be able to work full time, and we should be able to take care of our kids, and we should have no symptoms at all. So I think really normalizing the need for help and support is important in normalizing. Maybe you could even take some of the information today that you learned and say, I just learned that 5 to 7% of women actually experience this. And there's help. There's help from asking your doctor to finding providers that specialize in postpartum depression and understand what you're going through. So even encouraging that kind of support. I think there are lots of ways that you can support your friends and family.
Great. I think we'll finish up with this last question. What services are available to help parents, moms with things like transportation, food, clothing, baby supplies? How does a new mom know to talk to her doctor about these types of hardships?
So the first thing that we're doing is in our intake, when you come to see us as a new OB patient, or you have the pregnancy episode, every pregnancy episode we give this new OB questionnaire, and it asks about all of those things. So you can fill out a form, and then you're meeting both myself and you're also meeting the case workers, the case managers or social workers. They're meeting all of the new OB patients. And so we're making it known that if you have any of those needs, there are ways that we can help you get connected to resources, whether it's within Providence or within the community, that can help you with transportation, food, and clothing, baby supplies. I know that the Providence Beginnings social workers also work in the hospital. And so they're on that side of it too in labor and delivery and can address some of the needs even before they go home. So we're trying to get our faces into those new appointments. If we miss you at your new appointment, then we will see you when we're doing the screeners. We're trying to ask the questions, and we're trying to normalize the concerns that a lot of our patients have said they have. And so making our services known to every woman is really what we're trying to do.
Well, thank you again, Dr. Johansen, and please feel free to keep asking questions. We will try to follow up with questions via email. We will be sending a follow-up email in the coming weeks and would love to hear from you. Thank you for spending time with us today, and I do hope you can attend our next Doc Talk. Thank you so much.